بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, now we'll start a new series of lectures about the female imaging. And as you all know that I don't have enough experience in the breast imaging, but I can handle some of the pelvic female imaging, and this will be provided in about 4 lectures dealing with the anatomy and pathology of the female pelvic organs. And these are the items for discussion. I will provide some of the anatomy and techniques of examination. Then we will talk about uterine leiomyomas, then uterine adenomyosis, and then the second part of this talk will handle the issue of endometrial carcinoma, and will end by the cervical cancer. And in 2 other separate lectures, I will deal with ovarian pathology and the rest of the organs like adnexal lesions, vaginal pathology, and so on. And you know that to examine the pelvis for male and female, we usually use almost the same technique, but in the female patient, we would like to have some precautions and some more preparations so that we are able to adequately delineate the pelvic organs, especially the ovaries, which are somewhat difficult to be delineated by CT scan. Then in the CT technique, we use usually some gastrography to opacify the bowel loops, and we may need in some specific cases to inject gastrography in the rectum to opacify the distal part of the colon. Sometimes we need to put the vaginal tampons, especially whenever we are evaluating lesions in the uterine cervix or lesions in the proximal part of the vagina. And in many conditions, we usually need to inject contrast medium, and this is the regular dose for the adult female. The pelvis is scanned from the level of the iliac crest until we finish by the pubic symphysis, or even more down, to cover the area of the anal canal and the ischiocrectal fossa. And we use somewhat a small field of view to include the whole pelvis and to delineate the organs in a good manner. Sometimes we need to have the sagittal and coronal reformatted images, which are usually helpful in almost all of the cases. This is the regular anatomy of the pelvis, and we start almost near to the iliac crest, where we do not usually see anything apart from the bowel loops, and we can see the inferior part of the left kidney, as in this case, and also the inferior part of the liver. Then you can see the aorta and the IVC. Lower down, we can identify the bowel loops, which are delineated by the orally administered contrast material. And lower down, we still see the bowel loops and the psoas muscle and the vessels on both sides. Then more lower down, you will see the uterine fundus or the uterine colpus, the body of the uterus, and sometimes you can identify one or both ovaries as small, round, or oval-shaped structures on both sides of the uterine colpus. And lower down, you can reach the region of the anal canal and the ischiorectal fossa. And here in this example, you see the uterine corpus, and lower down, this is the urinary bladder, this is the uterine cervix, which is located between the bladder and the rectum, as you all know. And this is the final image when you reach the, the distal part of the cervix, and this is the vaginal vault, this is the anal canal, and this is the urinary bladder. And here, of course, the ischiorectal fossa filled by fat on both sides. And sometimes we may prepare the bowl using water or mannitol in order to distend the small bowel loops and to separate them from other pelvic structures. But in most of the cases, the radiologists usually feel somewhat familiar with the gastrografin in the bowel loops. And this is the coronal reformatted image of the CT scan after contrast injection. And you can see the uterus with the endometrial cavity, which is not enhancing, similar to the myometrium, for example. And this is the axial image. This is the uterine corpus, endometrial cavity, and this is the rectum. The sagittal image will show the full configuration of the uterus, including the fundus, the body, and the cervical canal. Then MRI is, of course, considered uh, as one of the most important imaging techniques for evaluation of the female pelvis nowadays, in particular the uterus, and whenever you are in the way to stage some of the neoplastic lesions, as we will see. Then the usual examination technique is performed by one of the high field scanners, and we use one of the pelvic or torso phased array coil, and there is no special bowel preparation needed for MRI except that you may inject some spasmolytic agent to reduce the bowel peristalsis to avoid some artifacts. Then the patients are instructed to void prior the examination, and of course nowadays the examination is not that long, so the patient can tolerate the exam without the need to go to the toilet. Then the standard position is the comfortable supine position for examination, and we use all the available pulse sequences, including the T1 and T2, and maybe the gradient images in the axial, sagittal, and the coronal planes. We select the field of view which is suitable for the patient size, and we usually scan the pelvis at 5 millimeter slice thickness. We will leave about 2 millimeter interslice gap, and in many conditions we need to inject the contrast material. It's better to examine the female patient in the second half of the menstrual cycle, but this is not a rule. Sometimes, as I have said, we may use the vaginal tampons, especially whenever we are examining the cervix and the vagina. And this is the menstrual cycle, starting by the menstrual phase, followed by the proliferative phase, and this is the secretory phase. And this is the ovulation or the ovarian cycle, starting by the primary follicle, the secondary follicle, then the vesicular follicle, which will ovulate and transform it into the corpus luteum, then uh, progresses to the corpus or degenerates to the corpus albicans. I will um, uh, touch this issue in details in the section of ovarian pathology. Then one of the important pulse sequences which should never be omitted in the examination of the female pelvis is the sagittal T2 weighted images. And this is very important to assess the uterine anatomy and most of the uterine pathology, especially whenever you are inquired about the zonal anatomy and endometrial pathology. Then sometimes many of the radiologists will prefer the axial oblique images, which are obtained perpendicular to the axis of the uterine body. And one of the important issues is sometimes you need to scan the upper abdomen for possible renal pathology, especially in cases with uterine anomalies, and also in cases of malignancies searching for metastatic deposits. And in the reproductive age, the uterus will appear like this, and the size of the uterus is about 6 to 9 centimeter long, and its weight is about 50 grams. The uterine cavity is lined by endometrium, which is of bright signal, and the T2 weighted image. And you know, the fluids are of bright signal in the T2 weighted image. Also, the fluid in the urinary bladder is bright. Then you see this dark band, which is known as the junctional zone, and you see the gray muscles of the uterine body, which will appear of intermediate signal in the T2 weighted image. And you can continue into the cervical canal, and this is the upper part of the vagina. You know that the uterus is an extra peritoneal organ. It is covered on its surface by the peritoneal cavity, which is also covered the urinary bladder vault. In one of the issues that our colleagues used to comment upon in every examination of the female pelvis is the position of the uterus. And you know, this is the normal position, and sometimes the uterus is anteverted, and there are some degrees for this anteversion. But you see here, this is the uterus, which is uh, totally anteverted, lying in the presacral area. This will not interfere with the pregnancy, for example, and it will not produce any symptoms. Then one of the incidental findings that we may face during our examination is that you can see some cystic lesions, small cysts in the uterine cervix, and these are known as Nabothian cysts. They are retention cysts in the cervical mucus glands, and they are benign, of course, containing fluid or mucus. They appear of bright signal in the T2 weighted image. They are considered by many as an incidental finding. And if you have the sagittal reconstructed image of the uterus by CT, you cannot, of course, see the zonal anatomy, but you are able to measure the uterine size, and you see the contour, and also you assess the thickness of the myometrium, for example, and to see masses coming out from the body of the uterus. But in order to appreciate the zonal anatomy, which is made of the three layers I have mentioned, there should be an MRI, and this should be in the T2 weighted image and preferred to be in the sagittal plane. And here you see the endometrial cavity, and you see the junctional zone, and you see the myometrium, which is of intermediate signal. The junctional zone is dark, and the endometrium is bright. The junctional zone normal thickness should not exceed 5 millimeter, and this is very helpful in the assessment of the uterine adenomyosis, where you can see that there is significant increase of the thickness of the junctional zone, as I will mention, and it is stated that the thickness of the junctional zone over 12 millimeter is diagnostic of uh, adenomyosis. Then you know that there are several changes which occur in the uterus during the menstrual cycle. This is the proliferative phase, where you can see the zonal anatomy in the T2 weighted image. The endometrium is bright, the junctional zone is thin, and it is dark. The myometrium is gray. Then in the mid-secretory phase, you see that there is appreciable thickening of the myometrium, relative distension of the uterine cavity, and the thinning of the junctional zone. In the menstrual phase, you see some blood clots inside the uterine cavity, and you see that it is regaining its normal configuration and signal intensity. And in order to see the value of T2 weighted imaging, you can look to the same images in the T1 weighted image. In the T1 weighted image, you see the shadow of the uterus, and you cannot identify the zonal anatomy. But in the T2 weighted images, in the axial and the sagittal plane, you can see the zonal anatomy, you can see the endometrial cavity, and you can differentiate between the junctional zone and the myometrium. And this is the appearance of the uterus during the menstrual cycle. This is T1 and this is T2 weighted image, and you can see, you know, that the they phase by the presence of blood clots inside the uterine cavity. And this is an important issue. If you can look here and you see some loss of definition of the junctional zone and relative abnormal signal in the myometrium. But the scan obtained immediately after this one showed normal appearance. And this is known as transient uterine contractions, which may disturb the signal intensity of the myometrium, leading to a false impression that you are dealing with, for example, a focal uh, adenomyosis, for example. But this is just a simple contraction, and in the next image or in the other series, you will see the normal junction, the normal zonal anatomy. Then the cervix has some different anatomic details when compared to the uterine body, but this is one of the issues that you should notice during the examination is the presence of high signal folds within the endocervical canal, and these are known as the palmate folds, which are considered a normal find. Then this is the appearance of the uterus and the cervix in the T1 weighted images and in the T2 weighted images. In the T2, you are able to see the cervical stroma, the endocervical canal, and in the T1 weighted image, these details are usually masked. And after menopause, it is expected that the uterus is getting smaller, and the myometrium has a lower signal compared to the myometrium in the reproductive period. This is the postmenopausal uterus, and you can notice that the myometrium now is relatively more dark compared to the intermediate signal of the myometrium in the younger age or before menopause. Then the junctional zone is not well defined, and the endometrial cavity is small or atrophic, as you can see here. But the cervix is not liable for these changes. The cervix may maintain its normal size and zonal anatomy. And then, sorry, we'll start the pathologic lesions that occur uh, in the uterus, and we'll start by the congenital anomalies affecting the uterus and the tubes. Then you know that the uterine corpus, the isthmus, the cervix, and the upper two-thirds of the vagina are derived from the Mullerian ducts, while the lower third of the vagina is derived from a separate structure, which is the urogenital sinus. Then these are two separate entities, and each will be liable to abnormalities related to the site of origin. The congenital anomalies of the uterus are uncommon, and they represent about 1 to 3% of the population. These anomalies are usually diagnosed by many radiologic techniques that was previously the hysterosalpingography was one of the major tools that's still used up till now for evaluation of suspected uterine anomalies. Then the transabdominal ultrasound and transvaginal ultrasound, sonography, and MRI, of course, is one of the most accurate tools for evaluation of congenital anomalies of the uterus. Then the anomalies will present clinically according to the age of the patient. In the childbearing age, the patient may present by infertility or spontaneous abortion or premature delivery or fetal intrauterine growth retardation or difficulties during delivery. While in infants, they will may present by hydrometrocolpus, distension of the vagina and the uterine cavity by secretions, or in adolescence after the start of the menses, they may present by amenorrhea or hematometrocolpus, meaning that the vagina and the uterus are distended by blood. Then this is the diagrammatic representation of the possible uterine anomalies. This is the normal appearance of the uterus, and this is what we call unicornuate uterus. This is uterus didelphys with two separate uterine cavities and two separate cervical canals, and then maybe in most of the cases a vaginal septum as well. Then bicornuate uterus, there is some separation between two bodies of the uterus, but they usually unite at some distance from the fundus into a single uterine cavity and maybe a single cervix. But sometimes, in cases of bicornuate uterus, you have two uterine cornua that are fused at a certain distance, but each uterine cornua has its own cervical canal. And this may simulate the uterus didelphys, but you remember that the uterus didelphys, there are two separate uterine cavities and two separate cervical canals. But here there is some way fusion between the uterine corpus on the left and on the right, but each one has its own endometrial cavity. And this is what we call the septate uterus, where the configuration of the uterus is maintained, but the cavity is septated. And you see, it depends on the size of the septum. The septum may involve the whole cavity, and this is septate, and involve part of the uterine cavity, and this is subseptate uterus. And sometimes the septate uterus may have also a septum in the vagina. And finally, you get the arcuate uterus with some fundal depression, but the configuration of the uterus, the cavity, the cervical canal are maintained. We start by group 1 or class 1 uterine anomalies, which are known as dysgenesis of the uterus. And here you have agenesis or hypoplasia of the uterus, as well as the upper two-thirds of the vagina. You can see a very small size uterine cavity, but the tubes are present and they are patent with normal peritoneal spill, and this is through salpingogram. And this is what we call infantile uterus, where you see the size of the uterus is very small, but the fallopian tubes are maintained, they are normally developed, and also they are patent, spilling the injected contrast material into the uterine cavity. The class 2 is unicornuate uterus, and that's to say that we have a, a single uterine cornu with the second one is rudimentary or atrophic, and sometimes no other cornu is present. Many times you get a cornu, but it is not connected to the uterine cavity, or you got a rudimentary cornu which is connected to the uterine cavity. If the cornu is connected to the uterine cavity, it will fill with contrast material during hysterosalpingography. But if not, and you see here only one uterine cornu, you may expect that there is no other cornu at all, or the cornu is present but it is not connected to the uterine cavity, and this information is only obtained by MRI or by the transvaginal ultrasound. In many cases, in this congenital anomaly, you got some renal malformations as well. And here you see a single uterine cornu, a single fallopian tube, and the possibility of another atrophic cornu needs further evaluation by MRI. In this case, by hysterosalpingography, you see a single uterine cornu, and by MRI, you see a single cornu. This is the rectum, which is distended by fecal matter, and you cannot appreciate the presence of another rudimentary cornu. And this is the same case. Here you see single cornu by hysterosalpingography, and you see the cornu well demonstrated by MRI T2-weighted image with no rudimentary hole. You came to the second or the third class, which is uterus diadelphys, where there is complete non-fusion of the Moravian ducts with formation of two separate uterine cavities and two separate cervical canals, and the vaginal septum is usually present in about 75% of cases. And here, by hysterosalpingography, you may need to introduce two hysterosalpingography cannulas for evaluation. And you put cannula in one of the cervical canals and another cannula in the second cervical canal. Then you got the opacification of the uterine cornu. And this is uterus diadelphys. You should remember that in uterus diadelphys there are two separate uterine bodies, two separate uterine cavities, two separate cervical canals. But sometimes it's difficult to say for sure if this is a let's say uterus didelphys or bicornuate uterus, then you should remember that the bicornuate uterus, there is some fusion between the bodies of the uterus and at some distance from the region of the fundus. And here is the uterus didelphys. You can see two separate uterine cavities, two separate cervical canals. And this is uterus didelphys with a fibroid mass inside the uterine cavity here. You see the body of the uterus on the left with its cervical canal, the body of the uterus on the right with its cervical canal, but the uterine cavity is distended by this low signal mass, which is characteristic of uterine fibroid, as I will mention later on. In bicornuate uterus, there is some fusion between the bodies of the uterus, and there may be a single cavity um, um, at a distance from the fundus, or there may be two separate uterine cavities and two separate cervical canals. And this is the appearance of the bicornuate uterus. There is a fundal cleft which is more than 1 centimeter from the external uterine contour. And you see, this is the body of the uterus. The body of the uterus on the right side, endometrial cavities, they are fused here into a single cervical canal. This is what we call bicornuate unicolous uterus. And sometimes you got two separate uterine bodies and two separate cervical canals. But here you see a bicornuate unicolous uterus with a single cervical canal, which is the uterine bodies are opacified by a single cannula introducing into a single cervical canal. And this is bicornuate uterus, where you see there is some fusion between the bodies of the uterus, and then you see the endometrial cavity, and here you got two separate cervical canals included in a single cervix. Then this is bicornuate uterus, another example, two separate uterine cavities, two separate cervical canals, but you see the fusion of the uterine bodies here, and this is bicornuate bicolous uterus. And the scans of the abdomen showed that there is a single kidney on the right side, which shows compensatory hypertrophy where the left kidney is not present. And septate uterus means that the uterine cavity or the configuration of the uterus is almost within normal, but there is a septum within the cavity, and this septum may be complete, as you can see here, or incomplete like this one, which is called the subseptate uterus. This type of uterine anomaly, according to the literature, has the poorest reproductive outcome. And here you see a cleft which is less than 1 centimeter from the uterine fundus, and this is what we call the subseptate uterus, and this is also subseptate uterus. You see a cleft within the uterine cavity dividing the cavity into two. Then there is fusion of both cavities into a single cervical canal. CT, of course, is the least of the imaging modalities to identify uterine anomalies, but sometimes you can see this as an incidental finding looking for other pathology. And here, this is the uterus. There are two separate endometrial cavities with a septum in between, and this is septate uterus by CT. This is subseptate uterus with a septum near the uterine fundus, dividing the cavity into two parts with a single cervical canal, and this arrow points to an incidentally found uterine fibroid. And this is also an example of septate uterus, partial septation with two endometrial cavities in a single cervical canal. Then arcuate uterus is considered by many as a normal variant. There is some depression in the uterine fundus as seen by MRI and also by hysterosalpingography, as you can see here. And this arcuate uterus has no negative effects on pregnancy. This is arcuate uterus, and there is some hydrosalpinx on the left side, but the right tube is patent, spilling contrast material in the peritoneal cavity. Then this is arcuate uterus, and you see this fundal depression. This is the endometrial cavity, which is not divided, and you see the junctional zone, and also you can appreciate the uterus, the ovaries, sorry. Then we start by one of the common pathologies affecting the uterus, and this is the uterine leiomyomas or the uterine fibroids. This is considered the most common uterine benign tumor, and the incidence is about 25 to 50%. About 10% of leiomyomas will occur in the cervix, but most of the uterine fibroids are seen in the uterine corpus. This is very common in patients with no children, and also is very common after menopause. Then the clinical presentation of uterine fibroid will include abnormal menstrual bleeding, menorrhagia, and of course with consequent anemia secondary to the blood loss. Pelvic pressure symptoms: if the uterine fibroid is large, it will compress the urinary bladder and it will also compress the rectum. And sometimes it may interfere with pregnancy or may lead to some complications during pregnancy. Uterine fibroids can be diagnosed by the plain X-ray if you see this finding, a mass which is calcified in the pelvis of a female patient. And then the diagnosis of uterine fibroid is the most common diagnosis for this appearance. This is also a uterine fibroid incidentally discovered during an intravenous urography for assessment of urinary symptoms. And if you perform hysterosalpingography, you can see that the uterine cavity is enlarged, and you may appreciate some filling defects inside the uterine cavity, and this is the submucous fibroid, or you may get enlargement of the uterine cavity with irregular borders, and this will be secondary to fibroids in the wall of the uterus, what we call interstitial fibroids. And this is the appearance of fibroid by ultrasound. It will appear hypoechoic, and if you use the Doppler facility, you can see some vascularity within the mass. And this is the appearance by CT, and you got a lobulated mass which is of almost similar density to the muscles of the uterus, and this mass may be small, may be large, and usually it contains calcification in up to 10% of the cases. And this is the uterine cavity. This is the uterine, the myometrium, and there is a mass here, and this is uterine fibroid. The fibroid will appear in the CT images of similar CT density and enhancement to the myometrium, but sometimes due to some degenerative changes in the fibroid mass, it will appear somewhat hypo dense or less enhancing compared to the myometrium. And this is a very big uterine fibroid which contains a lot of dystrophic calcifications, as you can see. Then this is the fibroid uterus, within the fibroid mass or within the myoma, you can see hypodensities, and these are due to some kind of degeneration within the fibroid, including cystic and hyaline degeneration, and also there may be fatty degeneration within the uterine myoma. And this is cystic degeneration within uterine fibroids. You got some fluid density within the masses affecting the body of the uterus. And this is also an example of fatty degeneration of uterine fibroid. You got some hypodensities representing fat within the uterine fibroid, which is, as you can see, not enhancing as similar to the myometry. By MRI, the uterine fibroid has a classic appearance, which is a well-defined mass either within the uterine cavity or within the myometrium or outside the uterus, the uterine cavity, and this mass will appear of low signal in the T1, low signal in the T2, and it may show some contrast enhancement after gadolinium injection. Of course, you know that MRI is relatively insensitive for detection of calcium within the uterine fibroids. But this is a classic appearance whenever you see well-defined masses within the myometrium or inside the uterine cavity, and this is known as the submucous fibroid. This is interstitial fibroid, and if there is a uterine fibroid here outside the uterus, and this is the subserous fibroid. And this is the sagittal T1 post contrast with fat suppression. You see the body of the uterus is large, and you see the uterine fibroids less enhancing compared to the enhancement of the myometry. And sometimes if calcification is prominent, it can appear on MR images, as in this case. This is the uterus, and the low signal rim as well as the low signal dots represents dystrophic calcification within this uterine fibroid. And this is an example of a big fibroid in the fundus of the uterus and the smaller one nearby. Both lesions show dark signal in the T2 weighted image, and they show some enhancement after intravenous contrast injection and this sagittal T1 fat suppressed image. Then uterine fibroids may show some signal void vessels at the margin of the lesion because they are vascular lesions. They may undergo hyaline degeneration or cystic degeneration or the hemorrhagic degeneration, myxoid degeneration. A lot of degenerative changes may affect the uterine fibroids, and this will be reflected on the signal of the fibroid mass. You know, the usual signal is dark in the T1 and T2, but if there is cystic changes, it will appear black in the T1 and bright in the T2. If there is hemorrhage, it may appear bright in both T1 and T2 weighted images. This is multiple uterine fibroids. This is the uterine cavity, and here is submucous fibroid, and this is another one with some degenerative changes inside. This is intramural or interstitial within the myometrium, and this one is also within the myometrium. This is the rectum, of course, containing some fecal material. Then one of the management procedures for uterine fibroids, which are big, is to do a selective embolization of the uterine artery. And in cases of big uterine fibroids, and you want to decrease the size or let this fibroid shrink, you may embolize the feeding artery. And this is an example of the huge uterine fibroid that was treated by uterine artery embolization. And this is the follow-up obtained 6 months after embolization, showing significant reduction in the size of the fibroid compared to the pre-embolization image. And here is an example. You select the uterine artery, and you inject an embolizing material. Then you got almost marked decrease of the vascularity of the uterine fibroid, which will be reflected later on the size of the fibroid uterus, which will shrink. Then sometimes you got too many uterine fibroids involving most of the uterus, which will appear like this. There are numerous uterine fibroids within the cavity and within the wall. We call this uterine leiomyomatosis. Cervical fibroids or leiomyomas, the incidence is about 10 or 6% of the uterine fibroids. They will have the same imaging findings similar to the leiomyomas arising from the body of the uterus. And they are liable for the same degenerative changes affecting the uterine myomas. And here you see a big cervical leiomyoma, which is protruding into the proximal part of the vagina. And of course, the main differentiating issue here, as I will mention later on, is to differentiate the cervical leiomyoma from cervical carcinoma, since the two other possibilities are considered extremely rare, which are lymphoma and melanoma. And here you see a uterine leiomyoma, which is affecting the cervix. And this is the appearance on the T2 weighted image, the appearance in the T1 weighted image, and the appearance after contrast injection with T1 fat suppression. هذا وبالله التوفيق والحمد لله رب العالمين. Thank you very much.